Hello, everyone. Welcome to another webinar from the Steps Forward Innovation Academy. Today, we'll be discussing our recently published Reducing Regulatory Burden Playbook. We want to clarify often misunderstood and overinterpreted regulations and offer some strategies to help reduce administrative burdens. Please note this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. So I'm happy to introduce my co-presenter. Alec, if you don't mind going back. Thank you very much. So Tracy Davis Bradley. Dr. Bradley is a Chief Integrity and Compliance Officer and a Deputy Designated Agency Ethics Official with the U.S. Department of Veterans Affairs in the Veterans Health Administration. My name's Kevin Hopkins. I'm a family physician and the Vice Chief for the Primary Care Institute at Cleveland Clinic. I also have the great honor to serve as Senior Physician Advisor for Professional Satisfaction and Practice Sustainability here at the AMA. Tracy, thanks for joining me on this webinar today, and I know we'll have a great time.
Looking forward to it. Thanks so much.
Thanks. Okay, we can go on to the next slide. So much of the content that we plan to share with you today is from this recently published playbook, from the AMA Steps Forward series, Reducing Regulatory Burden Playbook. The subtitle is Avoid Over-Interpreting the Rules. And so most of the content that we'll share today you can find here. You can scan the QR code that's also on the screen to stay up to date with Steps Forward publications from the AMA. And link to this one specifically so that you can save it for future reference. Next slide. So I mentioned that I'm a primary care physician, and I think it would be a disservice if we didn't start by talking about the time problem that exists in the delivery of healthcare, not just for primary care physicians, but for all of us. But we have a good example here of the time problem to take care of a panel of 2,500 primary care patients. This was from a study that was done back in 2005. The amount of time it would take per day to handle the chronic disease management for this number of patients is over 10 and a half hours. The amount of time it would take to deliver necessary and recommended preventative care, almost 7.5 hours. To handle acute care, the things that come up and the oh, by the ways, that's another 4.5 hours per day. If you sum that all up, it's 22.5 hours per day. So you've got less than 90 minutes to go enjoy time with your family. And this was based on a report published in 2005. If we go on to the next slide, this study was reproduced more recently for a panel of 2,500 patients today for chronic disease management, about a little over 7 hours per day. For preventative care, 14 hours, acute care, 2.2 hours. And the thing we didn't see in 2003 is the amount of time for documentation and inbox, almost 3.5 hours a day. Add it all together, over 26.5 hours per day. It's not possible. Even if we had the DeLorean to disrupt the time-space continuum. So there's a problem here, right? There's a disconnect. We can go on to the next slide. One of those things that causes unnecessary burden and inefficiency in our day-to-day work is things that are blamed on regulatory requirements and regulatory compliance issues. To that end, our AMA team has developed a series called Debunking Regulatory Myths. If you haven't looked at it, I encourage you to check it out. Scan the QR code on your screen. My team does these, and it's a series that aims to help organizations reduce administrative burden and increase physician satisfaction through clarification of often misunderstood and over-interpreted regulations. We can go on to the next slide. Here's some examples on the screen. We've already explored more than 25 issues. Topics are identified, researched, and then if it's found to be a regulatory myth, it's debunked. And a brief, easy to understand one-page summary document is produced and published, clarifying the regulation and citing the sources. These fact sheets provide leaders and physicians on the front lines of care delivery with clear guidance on how to interpret the issue at hand. These resources are intended to reduce regulatory guesswork and associated administrative burdens to physicians and their teams so that we can focus on what matters most, providing great care to our patients. The goal isn't to eliminate all regulation and oversight, but rather to sensibly reduce the unnecessary burden on clinicians. Next slide. This slide has a quote from Dr. David Baker, who's a good friend of our work at the AMA and the former executive vice president at the Joint Commission. And it comes to who makes the rules. Is it federal regulatory agencies? They often get blamed. Is it state boards of medicine, nursing, and pharmacy? Yeah, all the above. Is it health systems and practices? Often. We run into policies and procedures from a health system and practice standpoint that are meant to help us be in compliance with certain regulatory requirements, but they also come from revenue cycle, risk management, and information technology. On this slide, Dr. Baker's quoted as saying, organizations frequently establish stringent requirements well beyond our standards, that's the Joint Commission, and they then get scored as being out of compliance. We get blamed for this, and that's how myths arise, that we require things when we don't. So the Joint Commission, when they are around to survey a hospital system, not only do they survey based on Joint Commission and CMS standards, but also any policies and procedures that the organization itself has put in place to comply. Basically, they hold you responsible for doing what you say you're going to do. Go on to the next slide, please. This is a quote from Don Berwick. Don is a physician. He's president emeritus and senior fellow at the Institute for Healthcare Improvement, IHI. He's also a former administrator of the Centers for Medicare and Medicaid Services. And he quotes one study here that says, the majority, 78% of obstructive and wasteful rules identified by patients and staff are fully within the administrative control of healthcare executives and managers to change. So when our practice leaders or system executives blame regulatory compliance, sometimes that is the case, but often that's just a default response, and it is something that we can control or influence. I'd like to hand it over to Tracy now to talk through some of the adverse effects of over-interpreting regulatory requirements.
Thank you so much. I know potentially some of you are saying, so how is there a compliance officer on the call? I think we're supposed to be reducing regulatory burden. I'm here to, I guess, share, compliance, at least, a number of the colleagues that I have in this profession are very aware of the impact on workload, cognitive stress, the organization, and patient care. I think what's hard, and this is where, and I'm going to go through the specifics. I know in VHA, we often talk about writing the Cadillac policy when really all we need is a Chevy, and running into a lot of issues that, it's great to have subject matter experts in very specific fields, but often they get kind of very into best practice instead of thinking about what is narrowly required for what is needed. The burdens add up over time. From a workload perspective, I think we all try to balance kind of work-life, have a work-life balance. There is tons of documentation, not just for clinicians, but I know on my side, I am involved in documenting investigations. I'm involved with documenting a whole slew of conversations that we have with regulatory bodies. It gets to kind of have a bit of a cognitive impact on us. And I know there have been a number of conversations with colleagues of mine about just that burden, the overworked clinicians, especially when our goal is patient care. The issues with burnout. I think we had a lot of conversations about this following the pandemic, and lots of issues. I mean, it's been a perennial topic, but kind of happy to see that we're having more conversations about that and really kind of pushing to kind of streamline. Organizational. This is where I know I have the conversation the most with a lot of leaders here in the Veterans Health Administration. And we have the conversation about eroding trust between the field, essentially the doctors, clinicians providing the healthcare, and central office, who seems to be just lobbying policies over the fence and kind of wishing for the best. We don't want to be adversarial, but what we end up doing is creating these boundaries between us in which it's hard to get to a good kind of conversation. and a good understanding and kind of getting to a good halfway point. And then, of course, kind of what we are all really here for, patient care. I think all of us who, we're all patients ourselves too. And the excessive documentation requirements can get in the way of the connections between a physician and the patients. Once again, I do not need to kind of say this to any of you. I think what is for us in the Veterans Health Administration, the fact that our mission is to serve veterans, and sometimes these regulatory burdens get in the way of us actually serving our mission as well as kind of running a healthcare organization. Sometimes that excessive burden can also lead to harm in patients, once again, especially when there's burnout involved. Next slide, please. I hear this one a lot. It's a regulatory burden. Tracy, we've got to do it. And I tend to be the intermediary between a number of the folks who write the policies and the physicians in the field. What we try to make very clear is that the only thing that is a must-do is what is in law and regulation. But we've written these Cadillac policies. Again, we're trying to do our best, but what often happens is we have not thought about all of the other folks, so the hundreds of other folks who are also trying to do the best practice, and we end up with an excessive regulatory requirement, or excessive requirement, which actually is not kind of connected at all to a law or regulation. We'll talk more about that in a minute. We've been doing quite a bit of work. I know a number of us have been doing a lot of work to kind of address this. I more often than not end up, and I encourage all physicians to really have more conversations. Compliance can be your friend. A lot of the oversight bodies within your organization we're there also because we believe in kind of the patient-centered care. We are there because we believe in healthcare. I know I am at VA because I am committed to the mission. Trying to get it so everyone has a better time at work and can actually do what we are all kind of in the workplace to do, which is to care for the patient, is really top of mind for everyone. Sometimes we don't talk about it the same way. And so being able to get to kind of the understanding of what does the law actually say. And I do encourage you, and I have these conversations all the time. People call me and say, Tracy, is this a requirement? I am here, and your compliance kind of colleagues, privacy colleagues, your IT colleagues should all be ready to engage in those conversations. Don't be afraid to ask. Next slide, please. This is the conversation we have often. And I know Dr. Hopkins and I had a number of conversations about what should we actually encourage physicians to ask? And, in a way that's not confrontational. I frequently, kind of folks will reach out to me, have the conversation about, can you just show me where that law is? Or can you send me kind of the hyperlink to that law or regulation? A lot of times I also involve general counsel, because more often than not, we've overinterpreted the law. We have, once again, gone for that Cadillac version, and what is actually in the law, the regulation, the statute, is not actually what we've interpreted it to mean. And trying to get to truly kind of the letter and the spirit of the law is really critical. So being able to have that kind of common ground where we get really clear on what actually is the law, what is the regulation, is really important. We wanted to brainstorm some other questions that you could definitely ask your colleagues at work. When you actually get told, and I'm not going to read every single one of the questions, but I do want to go through some of them. I know the conversations that I encourage others to have, and folks often have with me, is, what does the regulation actually require? What are we actually having to do? Is this a federal or a state? Is there something else going on here? Is this joint commission? What are we talking about? What is often also problematic is it could be that the policy was written just fine, and actually it isn't an overstretch. But the way we've communicated it communicates it in such a way that makes us overstretch what it actually conveys. And so our ability to be clear on kind of what stakeholders need to know about that law and regulation is also really important, because sometimes we're kind of where we have a misstep as an organization is communicate that the folks that actually write the communications are not the ones who also are involved with the interpretation of the law. And sometimes it can be a communication issue versus an actual policy issue. I am often looking also for what are other organizations doing to address this, to comply with this. And gets to, like, I always look for, well, what's the Chevy version of this? Back to the Cadillac Chevy analogy. I want to understand what can we do to meet the requirements of the law without creating an overburden on our teams. Lots going on from when everyone is asked to do something versus just other specific groups. So is every physician actually asked to do this? Is it only special, specific groups? I know that there are some laws, sometimes federal, sometimes state, that require only certain specialties to be asking different questions. So being also clear about who is actually required to do this, what does the law actually say? Are there any other rules? Are there nurses who are also involved in this? Are there any other groups who are part of this? And back to always returning to letter and spirit of the law. What is the minimum threshold that we need to reach to actually get to compliance? And there are times when we are, and it feels like a fire drill, we are asked to get in compliance ASAP. You must do this. Everyone needs to get in compliance the next 2 weeks. That's a huge burden, especially when it involves people kind of dropping things or having to pick up or extra, working extra hours. It's really important so that we're clear that we always are comfortable saying, what's the organizational policy for this one? I want to better understand it. I want to make sure I'm clear not only on what's the law, but what have we actually said we're all required to do? Because sometimes things get lost in communication, and we're not always clear on what we have to do. Being also clear on, like, what have we communicated? What is the training? Is there actually a deadline in the law that requires our compliance? And then the last question, which is, what are the consequences if I don't comply? A lot of the conversations that I have with folks is like, so what if I just don't comply, Tracy? Like, what happens to me? Do you come to my house? Like, what happens? And so human nature, we need to understand that more often than not, organizations, unfortunately, are building these behemoths of policies and standards that are really not enforceable at all, and or virtually impossible to monitor. How would you even determine if someone is actually in compliance with this or not? Getting to something rational is really important so that we can all kind of work together and move forward. Next slide. Kevin, I'm handing it back to you here.
All right. Thanks, Tracy. I appreciate it. So we're going to talk through several opportunities to stop the unnecessary or low value work. And that has to do with de-implementation of unnecessary work that's due to interpretation of regulatory requirements. Systems and workflows often have built-in redundancy in the name of patient quality and safety. And while it's worthwhile to consider those things, we need to reevaluate and reconsider, especially when the redundancy creates significant onerous task work. When errors happen, sometimes it's a people problem, but often it's a process problem. If our people often work around a process and mistakes result, then there may be something wrong with the process. The other thing is we aren't good at stopping things. We're really good at adding things onto our already overflowing plate. But we're not really good at saying to ourselves or our teams, you know what, we don't need to do this any longer because it's no longer as much of a priority as it used to be. And instead, let's do this because this is actually more valuable to our health system and to our patients now. These unnecessary tasks that build up over time, they exert a heavy burden on the daily workload. And this is for physicians and also other clinicians and healthcare professionals, and it contributes to burnout. The idea of getting rid of unnecessary work can seem simple, yet also daunting. Many physicians, especially those who are already experiencing burnout, feel resigned to doing whatever work we're given. But with commitment from leaders, some concrete examples to start from, and processes to evaluate and implement effective changes, unnecessary work doesn't have to be just the way it is. It's essential to understand what is in your control. There are some things that we'll talk about today that may not be within your direct locus of control. And while specific policy requirements may not be under your control, asking questions about them is. So working with practice and organizational leadership is essential when you're examining legal and regulatory compliance and policy standards. It's also critical to engage key stakeholders, such as your legal office, Office of General Counsel, and compliance professionals, as well as information technology team members, and clinical, administrative, and executive leaders in your practice or system. They'll be necessary and valuable partners in raising awareness of the often unintended administrative burden, and also help in reframing the organizational interpretation to help relieve some of those burdens. Developing a shared understanding between leaders and practicing clinicians of what's in your control helps overcome resistance to change while building trust, transparency, and a culture of cooperation. We hope that this session will help you save time in identifying opportunities to de-implement unnecessary tasks at the practice and organizational level. So just as we talk about right-sizing clinical care by getting rid of low-value clinical care, like checking a vitamin D in every patient and leading to de-intensification of things like hypertensive management to get blood pressure to goal. We also need to think about this same practice in terms of practice or health system management. What's the low value clinical work or sometimes no value clinical work? And how can we work to de-implement those things, which will result in right-sized regulations? Oh, sorry, I have lost my place here for just a sec. We can go on to the next slide.
Jump in? I'm happy to share the example of kind of some of the things that we've done.
Yeah, you want to talk about the VA? That'd be great.
Yeah. So back in 2017, kind of so pre-pandemic, so a lifetime ago it feels, there was a concerted effort actually by primary care. There are times when the size of VHA, so we have over 400,000 employees, over 170 medical centers, over 1,000 community-based outpatient centers. There's times when our size is hard to manage. What's good sometimes, though, is we can kind of figure out things at scale and figure out what's working and iterate in a number of different areas. Dr. Angie Dinatolis, who's the head of primary care here at VA, in 2017 was able to lead a lot of efforts. She actually started an effort called Angie's List, which was a master list that she created for VHA physicians on how to really unburden our clinicians. It was initially a grassroots effort, headed up by primary care. We then kind of made it through the pandemic, and then immediately coming out of the pandemic, we realized, given kind of everyone's kind of mental overload, I think, and just in general exhaustion, we really needed to reduce regulatory burdens. There was a huge effort actually to rethink what are we doing here, rationalize, not not only things that are kind of policy related, but anything else that's all related to IT, the electronic health record, an enormous effort. We then kind of tested all of this out just almost a year ago. We kicked it off. We called them access sprints, and they were focused on very specific areas. So primary care, mental health. We selected 4 specialty care areas where there was both a great volume of veterans as well as kind of a number of risks that we needed to manage. And we set out to really figure out how can we reduce the burdens in each of these to drive the ability for physicians to get to spend the amount of time that they wanted to with their patients, and to really make sure that they could, get everything done instead of getting kind of burdened with administrative work. It was actually great. We were able to, so we had policy, IT, compliance, whichever of this, primary care, mental health, and we all went through every single one of the policies that was required for each one of those specialty areas. We kind of went out to the field, and in our case, it's 170 medical centers, to say, if you could remove requirements from any policy in VHA, what would they be? We kind of scoped it a bit. So like related to primary care, related to mental health. It was phenomenal feedback to get, and we were able to actually significantly reduce the burden in the places that people felt the most pain. We wanted to make sure that this was driven by our physicians. And once again, it was, kind of a massive effort. Everyone got on board, and those efforts continue. What we've realized, obviously, it's great to do kind of a jump in, let's do a sprint. But in order to sustain that work, we now have continuing work groups. So Dr. Dina Tolis and a number of other great physicians here in VA are partnering with workforce management, with a number of other, with IT, with the folks who implement the electronic health record. Everything is with the focus of reducing burden. If you can't get that type of focus, though, for your organization, I think that being able to start small efforts, once again, this one was a grassroots effort, really being able to get the ability to kind of get more team involvement across the organizations, that you can really make the changes that you want to see. Kevin, back to you.
Yeah. Thanks, Tracy, for jumping in there. That was perfect timing and a perfect segue. So, because you talked about sort of addressing it from a large system perspective, but not all of the folks on this webinar today work in large health systems, or certainly probably not government agencies. And so how can we start to do this? Because it's going to take starting small. We can go on to the next slide, Alec. So healthcare is one of the most regulated industries really in the country. The stakeholders who regulate, accredit, and govern physicians and healthcare practices include federal and state legislatures, agencies and boards, payers, and even a physician's own health system or practice. Additionally, associations, societies, advocacy groups, they make statements and non-binding recommendations that organizational compliance professionals sometimes misinterpret as regulatory requirements. As a result, physicians today face tremendous oversight and regulation from both internal and external sources. Unfortunately, a lot of the regulatory frustration is due to local practice and institutional policies designed to keep clinicians compliant with their organization's interpretation of regulatory requirements. Most health systems employ legal and compliance professionals to help manage complex regulations and standards and protect the organization from an audit failure. Often, regulations are challenging to interpret, and unnecessary patient care can cause hazards to the care team and to the patient. It can also result when policies designed to comply with regulations are out of date or not aligned with current practice standards, or designed for one practice setting, like inpatient medicine, and applied without modification to another, like ambulatory care. So in the next several minutes, we're going to try to quickly go through some very specific examples of things you could consider doing at your own practice or health system. Next slide, please. So this is formatted in sort of a stop this, start that format. So things that we should consider stopping if we're doing. Go ahead to the next slide, please. One password is enough. So stop unnecessary EHR password revalidation and two-factor authentication. This one change can save billions of clicks and keystrokes. At some organizations, approving or signing orders requires an identification step in the EHR that you have to do re-entry or tap your badge or do a fingerprint or answer challenge questions. Turn this off if your organization's doing it. There are no federal regulations that require two-factor authentication in an EHR for prescription approval of non-controlled medications or procedure orders. The DEA does require two-factor authentication to sign electronic prescriptions for controlled substances, but that's it. If an organization is not accredited by the Joint Commission, it's under no regulatory obligation to require that physicians sign orders for non-controlled medications or tests at all, as long as the approval is reflected within the visit note. Next slide, please. I'm going to share with you an example from my own health system and practice. This quote's from me. The sound of keyboard tapping and mouse clicking has become the sound of joy, leaving physicians through their fingertips. It was a long-standing Ohio State Board of Pharmacy law that required password revalidation for positive identification when we were signing all orders for prescriptions, whether they were controlled or not. We'd often been told, yep, it's a State Board of Pharmacy rule. And it was, until it wasn't. In the fall of 2022, we started asking questions about it again. And it turned out that the longstanding requirement affecting the way we sign prescription orders had changed. And yet no one directly affected by it seemed to know about it. The rule had changed sometime in 2021, but nobody knew. Go on to the next slide, please. So in 2023, we no longer had to do this, two-factor authentication to sign orders. Across our health system, this single change affected 805,000 orders per month, or 11 million orders per year that we were entering our password or tapping a badge. And when you add up the time, it's a total of about 12,000 physician hours per year. Multiplied by an hourly rate, that's about $2.25 million a year that we were wasting in badge tapping and re-entering a password for a system we were already logged into. And if we hadn't kept asking the question, can you please show me that regulation and where it comes from? We'd still be doing all that tapping and clicking and losing more joy with each one. We can go on to the next slide, please. Similar experience at Kaiser Permanente of Southern California. They put this same change into place, and it affects 1.5 billion orders per week in their system. 1.5 billion orders per week. We can go on to the next slide. Here's another one. If you order it, you own it. So some practices and health systems have a setting in the EHR enabled that automatically routes the results of all tests performed for a patient or PC. There's nothing that requires this. Consider turning that off. In fact, this practice can cause confusion about whose responsibility it is to review, communicate, and act on a test result, creating a patient safety hazard. Reviewing and managing test results should normally be the clear responsibility of the ordering physician. If results are shared, it should be with clear direction in order to help facilitate continuity of care. Next slide, please. In case you haven't noticed it, the volume of patient portal messages has increased steadily over the past decade and accelerated really over the last 3 years. Data from one US EHR vendor cites a 57% increase in patient portal message volume across all its US users between January 2020 and January 2021, coinciding with the start of the COVID-19 pandemic. Obviously, it's an unsustainable phenomenon. So, one thing you could consider doing is suppressing delivery of messages from a patient where they're just saying thank you. It's nice, it's kind, it's polite. Our culture and society doesn't do this as much anymore as we should, but there's no reason that we actually need to see it because it's not actionable. Many practices have begun suppressing the delivery of thank you messages and replies sent by patients that express gratitude to reduce unnecessary clinician inbox volume. Next slide. Here's a quote from Dr. Jennifer Parker, who's the chief of general internal medicine at University of Nebraska Medical Center. She said, "We made this change to suppress routing these thank you messages, and it prevented an estimated 50,000 messages per year from coming into care teams' EHR inboxes." Next slide. Stick with the vital vitals. There's no regulatory requirement to include a certain number of vital signs in ambulatory encounter documentation, regardless of specialty. As you know, the updated the updated CPT codes for billing for level of service now have to do with medical decision-making or time spent on the day of the encounter alone. So no longer do we have to check boxes or click buttons to have a certain number of vital signs or a certain number of data points in the history of physical exam. Include only what is necessary for the patient's care on that day, not worrying about checking additional vital signs to get an additional level of service. Next slide, please. Notification is not necessary. This refers to routing, the automated routing of patient event notifications directly to physicians' inboxes. Hospitals are not required to deliver electronic patient event notifications, known as ADT reports, directly to a physician's EHR inbox. They are required to send it, but how it's received is up to the individual physician or practice. These notifications could be routed to clinical or administrative teams. Some health systems have even bundled them so they get routed to an outside dashboard so that they can be accessed on a pull basis rather than on a push basis. These reports can also be batched and sent weekly or at a rate that is fitting your practice. Next slide, please. We should stop asking questions about mental health history for credentialing. Neither the Joint Commission nor the Federation of State Medical Boards requires that licensing and credentialing organizations, such as state licensing boards, physician credentialing services, and professional liability insurance carriers, ask probing questions about clinicians' past mental health, addiction, or substance use. In fact, they strongly advise against it. So if your system or practice continues to ask questions about this with physician credentialing about past history, that's something we could stop. We can go on to the next slide, please. Tracy, do you want to talk about some of the specific examples that we have that we could start doing?
Definitely. Let's move actually to the next slide. The requirements related to writing chronic medication prescriptions for the maximum allowed length of time. We get these questions often about what can we do related to very specific, types of prescriptions. We want to make sure that everyone is clear on what is required, what is not. There are a number of things that we can either turn off as functions or depends on how your electronic health record is set up. It also depends on how your reminders are set up in your computer. I see one of the comments in the chat about the ability to kind of just say no. I think the ability to say, is this really necessary? Is this one of those, this is one of those examples here where writing chronic medication prescriptions, it is important that we, as medical systems, make it clear, and I know you are all physicians, but I'm speaking more from a kind of a central office perspective. These types of things become such a burden for physicians. Make sure that you're able to clarify with all the different administrators in your team what you actually need to do, what you want to do, and kind of where you need to move forward. Next slide, please. There's a bit of a success story. So Dr. Murray Brown, internal medicine, former governor of the American College of Physicians, the ability to standardize prescriptions for chronic daily medications that were being written for 15-month supplies just once a year saved the staff at least 1 hour per day. I know we have found in partnership, some of this is, at least for VA, a lot of this has involved partnership with pharmacy benefits. A lot of times the ability to actually work with the folks in the pharmacy, coordinate that, make sure that we can all work together. Kind of the same, finishing off Marie's quote, with that extra hour, we had a time to identify patients who had missed appointments and reach out to provide health coaching. This example, this quote from Marie, also brings up the fact that there's a cost benefit. And I know there's just so many things that we're asked to do. The ability to actually do the other things that we really want to do, identify patients who've missed appointments, get more closure on other things that we're actually required to do, is so important for our ability to kind of feel good about our work and to not get exhausted. So again, this example really points to, if we can actually, once again, and listen to the quote that's in the chat box, our ability to say, we really need this. We need to make sure that this is something that we collectively, as a hospital or as a healthcare system, are able to do, can be a massive time saver. Next slide, please. Electronic health record. The requirements around being logged into the electronic health record, when we get logged out, the continuous entering of credentials to get into the electronic health record. Electronic health records all can be adjusted to have automatic timeout requirements that actually fit your practice setting. We find this in a lot of different clinics across the VA, that there's variable settings, or someone, somehow something got set up or got modified from the kind of the overall setting. Definitely encourage you all to kind of ask the questions, push a bit on this one. The ability to not have to continuously re-enter within kind of requirements related to patient safety and, kind of, once again, your practice setting. It's really important. Once again, hopefully, I know that there were some questions that came in before the webinar, questions about, but I'm concerned about being the person who's always asking the question. I'm kind of fearful of, I hate to say the word retaliation, but I'm really, I want to make sure. I think these are the types of things, though, about really reducing burden, saving you time, that are really critical to have those important conversations with the folks who can make these changes. Next slide. I get so many questions about coding updates and is this actually what's going on with billing? We end up dealing with massive amounts of documentation, the rerunning of all kinds of different records. There's a lot around the ability to deflate the note bloat. We encourage everyone to be able to move towards kind of an updated billing and coding guidelines within your hospital, within your healthcare system. It really helps to decrease documentation requirements. There are often times that we have a lot of conversations. In fact, we have a lot of conversations about this specifically. There are a lot of updates that keep happening, sometimes on an annual basis. But being able to get really clear on what is the current status for billing and coding guidelines to reduce the documentation requirements, having to sign on tons of different sheets. These are important conversations. These are things that you shouldn't have to do. Next slide, please.
Hey, Tracy.
Yeah, you want to go for it?
Well, I'm just noticing the time, and I want to make sure we have some time to get to the questions before we run out. All the slides will be available to everybody, and like I said, this is all in the playbook. So a couple of these last tips: start billing appropriately for preventative and problem-based care. A lot of people under the misconception you can't bill for preventative service and problem-based service at the same appointment. You can, and we should, because otherwise we're not getting paid for the work that we're doing. Next slide, please, Alec. And then involving other team members in tasks that they can help with, that you don't need to be a physician or an APP to do. Things like order entry, things like data entry into the EHR. We spend a lot of time looking at a screen, touching a mouse, and typing on a keyboard. And not all of those tasks require the credentials of the person who typically does them. Next slide, please. Allowing verbal orders. So this is a big one, and we've had ongoing conversations with the Joint Commission and CMS about this to clarify their guidance on verbal orders. And we can use verbal orders. The setting matters. The only restrictions on verbal orders in regulatory guidelines are from CMS, and it's specific to inpatient medication delivery. So I can say more about that later if people have questions, but let's go on to the next slide. This is just sort of a continuum that we've put together to help you think about how you would frame this up in your own practice or organization to identify, research, clarify, make changes based on what you found, and then quantify the impact and share the successes. But there's a lot of this work that can be done and should be done. And like I said earlier, the natural default when we hear it's a regulatory requirement is to sort of like slump our shoulders, put our head down and say, well, okay, I'll go on and do my work, but we should ask questions about it. So Tracy, maybe you and I can tag team on these questions. Let's see, how do you filter thank you messages from patient advice messages within Epic? So it's an IT solution, so you can't filter it like in Epic by like something on your screen. It has to be done by your IT team. But it's relatively easy to do and can really offload a significant number of messages that aren't particularly hard and may in fact be a little bit rewarding, but adds to the clutter of unnecessary volume in the inbox. How do we hold regulatory agencies accountable for providing effective regulations? It's good to do the extra work, yep. But how can we advocate? So one way is our AMA advocacy business unit helps to do this. I mentioned the Debunking Regulatory Myths series earlier. When we run into things that actually are true regulatory requirements that don't make a lot of sense or add to the unnecessary burden for healthcare teams, we will pass that off to our advocacy team for advocacy at the state and federal level to work on getting some of those things changed. I'll also say we work pretty closely with folks at the Joint Commission and CMS. Oftentimes these regulatory requirements are written pretty vaguely for a reason, and it often has to do with the interpretation of them. Their intent is to try to give us a little bit of leeway while still ensuring the patient safety and quality goals. But often our health system or practice overinterprets them, and we stay so far back from the line that we've actually handcuffed ourselves as a result. Their desire is not to make things more difficult. In fact, oftentimes regulatory compliance professionals and these agencies, when we bring something to them, they say, we had no idea that it was creating that negative unintended consequence. Tracy, you have any other insight in that?
Yeah, no, it's really the feedback loop. I think very often in conversations, whether it's CMS or Joint Commission, very often, I mean, back to what Kevin just stated, folks aren't aware of the impact that it's having. And so your ability to actually show some of the information about here's the burden that it's creating, here's the amount of time we're now spending, given all of these different requirements. I don't think anyone intends to do this often. I think it ends up being oversight. There are sometimes also, and I will say, a lot of lobbying groups that are pushing for very specific requirements that may stretch beyond kind of what is kind of necessary, but it's really a conversation and ensuring even your, I'm not sure how you each call the group, but essentially public relations, we have kind of a congressional and legal affairs groups, being able to actually have those conversations with either regulatory agencies or some of the lobbying groups is important to get to kind of right size.
Great, thank you. Another question from the chat, isn't the mental health question or aren't the mental health questions a CMS regulation? So an important distinction here. What is asked about and should be asked about is current impairment due to mental health or substance abuse issues. What we shouldn't be asking about is past history of those things. So if a physician or an APP had a history of depression, and maybe they were even admitted to the hospital and put on medications, and that was 10 years ago, and now we're asking about it on an application for credentialing, it's probably not as relevant as it may have been at the time that they were going through that. So it's an important distinction, an important thing for us to consider. Another good question, have you considered that physicians are concerned about being team players and employed physicians may fear for their jobs? Yeah, absolutely. So I think when we're going to challenge this type of stuff, it's all in the approach. If we approach with humility and a genuine desire to know and understand, and by asking questions, I think it's going to be hard for anybody to fault us for that. Because if I know why something's required, I'll be more engaged in actually making sure that it gets done. If I ask questions, we find out that it's not required, then that's a whole different conversation. So I think it's all in the approach, and there's certainly an art to that, but we shouldn't be concerned about our jobs or about our workplace relationships if we're asking questions in a favorable way. Let's see, what else we got here? Sorry, now things are moving on me. Can the AMA lobby that regulatory agencies themselves have a legal requirement to monitor their own policies for effectiveness? If I prescribe a med, I'm responsible for monitoring that patient. Yep. They seem to have no responsibility for monitoring the effectiveness. So yeah, that's a great question. Yeah, absolutely. We should, and I believe that the AMA does do this. It's probably been an area that you're right, has not had a lot of direct line of sight as far as accountability, but it's happening more and more. And like I said, the regulatory agencies, they're not generally looking to cause us more harm. Everything that was once required or considered about being required was considered for a good reason, probably because it contributed to patient safety, quality, patient experience, all of those things. But over time, priorities and things shift. And so they should be updating their policies. And I know they do review them with regularity, but they may not fully understand the adverse consequences. On the Debunking Regulatory Myths landing page, there was that QR code. That'll take you to the ability to send us your myths. If there's something that you're told is a regulatory requirement, you're not quite sure about it, and our team would be glad to look into it and see if we can run that to ground. Let's see, what else we got?
And I can add, while Kevin's looking for one of the next other questions, sometimes the efficacy or kind of the research that went into the policy when originally written may not be kind of at the same point, or it may not have the same quality impact now, given kind of changes in a lot of other things. Being able to require you look back at that and ensure that it is having the quality impact, the impact on the patient that you're intending, or an impact that you're intending in the workplace. There are a lot of policies that need to be relooked at. Totally agree with that.
Yeah. Okay, thanks. So just a couple other things, and then I'll highlight some opportunities that are coming up. Where can we find medical documentation requirements such as op note, exam, procedure? I cannot find specific requirements under the MAC websites. So one place is to go to the AMA website and look at CPT, billing and coding guidelines and requirements. AMA does all of that, and you'll find there the actual documentation requirements. There are some that CMS also has in addition, but those are reflected in the AMA CPT guidelines. What are the federal regulations regarding use of certified interpreters, specifically if a patient refused or declines use of interpreter? Is it legal to require the interpreter to listen to the visit to be sure that the conversation was understood? I do not know the answer to that. Tracy, you have any idea?
The only place where we've dealt with this is more in relationship to Joint Commission. And so I would recommend looking there. The guidance is broad. And so sometimes that is more specific to the organization or your specific hospital.
Yeah. All right, let's go to the next slide. So thank you for the questions, and there are probably more that we didn't get to, but hey, if you want more, get the latest practice innovation solutions directly to your inbox. Subscribe to the AMA Steps Forward newsletter and the Pearl of the Week email series, and follow us on LinkedIn. QR codes are on your screen. Like I said, everybody will have access to these slides. Next slide, please. Also, I want to talk about the AMA Steps Forward Innovation Academy Learning Collaboratives. This is something new that we're launching this fall. If you scan the QR code, you'll have more information about this. I will be helping to lead a learning collaborative starting Thursday, October 10th, on exactly this topic of reducing regulatory burden. So we would like to invite all attendees who may have interest in that exciting new learning opportunity to enroll. You'll attend 4 physician-facilitated webinar sessions over 6 months and commit to executing system-level change and measuring its effectiveness. As I mentioned, that one starts on Thursday, October 10th. If you have an interest in attending, scan the code on the right and click the link in the resources, or click the link in the resources widget on your console. There in the resources widget, you'll also be able to find today's slides and other suggested content from today's discussion. For additional resources to support your physicians and staff, please visit the American Medical Association website or stepsforward.org. You may have also noticed a survey widget on your console. Please take the time to answer the questions there. Your responses help guide our upcoming programming to deliver webinars you want, such as the one you saw today. You can also register now for our next webinar from the Innovation Academy by following the link on your console. Thanks again for joining all of us. Dr. Davis Bradley, thank you so much for your time and expertise and partnership in this. Thank you all for joining, and we hope to see you again soon. Thank you.
Thank you.